So, hearty welcome to one and all to the 10th episode of the Refractive Grand Rounds and a very auspicious day that is Guru Purnima. And I wish all seniors, all colleagues, all of you a very, very happy Guru Purnima. I think this journey, which we started 10 weeks back, has really enriched all of us in a lot of aspects of refractive surgery, keratoconus, and I'm ever grateful for this lovely group for this holistic learning. So what better day to invite my dearest dad, Dr. Ravindra, here for today's talk on hyperopic LASIK. So why we thought we should have a separate seminar for this is I think hyperopic LASIK, many refractive surgeons are not very keen on to do a surface, and few of them opt for an ICL, but ICL again very challenging because the anterior chamber depth and the eye is small. So why are not many of us comfortable? One thing is, I think every stage from planning of the surgery, getting the right refraction is very tough. And surgery as such, which you do a surface or a flap is tough. And a lot of patients we tend to read and see about the regression factor. And a lot of the angle kappa is different. So again, planning is a little tricky and a lot of issues like this. So we thought we should have a dedicated session. And who better than Dr. Ravindra, who has been claiming to have very good results in hyperopic from decades back. So he has extensively done a lot of hyperopic treatments, which obviously has given good results. That's why he continues doing it. So who better than him? So I invite you, Dr. M.S.Ravindra, for this session, and we'll just go through. He has a extensive presentation on how do we plan, how do we do, what are the tips and tricks we need to follow in surgery, and let's go through that once. And any questions we can always put it up, and he can stop in between and take up the questions whenever needed. So without any further ado, Dr. Ravindra, it's all yours.
Yeah, good evening. Guru Purnima stands out today, and the very fact that we're all learning means that all of us are gurus. And on the other hand, all of us are shishyas all the way from beginning of our lives to the end of the lives. And one has to remain, as I keep telling all the time, student every day. I would tell everyone, that's my favorite statement, that unless you learned 10 new points that you did not know yesterday you're not aware of it, today you learn 10 new points, don't go to your bed. So if you follow that, you'll be treasured with knowledge, treasured with information, and that certainly will take you a long way in enriching your life. Am I clear with my presentation?
Yes, very clear.
Fine. Greetings from Karthik Netrale as well as Jyoti LASIK Vision Center. As Dr. Deepi mentioned, hyperopia is one of the fond diseases or changes in the optics of the eye. It's not a disease, but changes in the optics of the eye. And it's associated with many problems, as you're all aware. There can be anisometropia, there can be amblyopia, there can be eccentric fixation, there can be subnormal vision, and maximum number of children are hyperopic, but somehow it's not clinically evident because of the accommodative facility that we have. Patients can accommodate and neutralize the hyperopia. That's why, to look outwardly, it looks as though myopia is more common than hyperopia, while it's other way around. I have no financial interest except that whatever I show you are all used by me. When you do a LASIK vision correction between a myope versus a hyperope, I feel certainly that hyperopes are much happier than myopes. Not that they got back their vision, but the accommodative spasm that they have gets relieved, and they are going to be much more comfortable in the challenging near work that we're all very bombarded with these days. So some of these patients do wear a contact lens. As in myopes, you will have to ask them to discontinue contact lenses 1 week, 2 weeks, 3 weeks, or 4 weeks, depending upon how long, what kind of contact lens they're wearing. If they're wearing a simple contact lens, I would certainly prefer 10 days of monthly contact lens discontinuation. If it's a toric lens or an extended or long-term wear lens, 3 months, 6 months, like that, they should stop at least for about 3 to 4 weeks time. Aim at stable refraction, stable topography, and stable pentacam. You do it about 10 days later, again 20 days later, and again 30 days later, and they should have similar readings in that. This applies to the refraction also. Don't do refraction soon after taking out the contact lenses. And the basic idea is everybody talks about regression in hyperopia. Regression is a thing of past. It's not with present modern LASIK machines. Of course, with the older machines, with the old understanding, older treatment patterns, you had regression. But then ever since we started using laser, that's about 2 decades ago, I have not seen regression at all in hyperops. Let us look at why did we land in a situation where everybody talks about regression. So ARK is always shows under values, so you cannot depend upon auto refractometers. You should do a dry refraction with fogging. All of you are aware of fogging. Fogging, 5 minutes, 10 minutes, you can keep on fogging and doing retinoscopy. That's the way to find out whether the patient is still accommodating or contracting his ciliary muscles. Cycloplegic refraction is a must. Propicamide has no cycloplegic effect. Cyclopentolate has some effect, but all hyperopes, at least once in their lifetime, whether you're prescribing glasses, contact lenses, or if they're coming for the first time to an eye hospital, you should do a cycloplegic refraction, and you will have a lot of cases with the surprise element of hidden hyperopias. And if you don't do a homotropin refraction, formal homotropin refraction, that is one of the strong causes why you get a regression. You're undercorrecting because you have diagnosed or evaluated a lower hyperopic power in a patient who has got much higher. There can be as much as 2 to 3 or even 5 diopters of hidden hyperopia in some patients. In hyperopia, it's always important to, we have a fascination for binocular vision assessment at Karthik Netralaya. We evaluate them, we have specialists trained in that. We look at binocular vision status and possibility of amblyopia. Even one line difference or a half line difference between the two eyes could be an amblyopia related blurring of vision. And one thing that you should always look at is take a direct ophthalmoscope. You would have kept it somewhere, and always check the fixation pattern. Even if the vision is 6 minus, you are supposed to check the fixation pattern. And these patients may not be having steady foveal fixation, which is most desirable when you want to put a patient on under the LASIK machine. So cover test is again very important, is a part of binocular vision status assessment. You do it for distance, you do it for near, do it with and without glasses, and see what kind of phoria or tropia the patient, intermittent tropia the patient has. These are all important in consideration of giving prognosis to the patient that he's going to be very happy after the LASIK. Pupillometry is again extremely important, both mesopic and photopic. OPT scan that we use in our hospital, you cover it up with a black cloth, so you create a mesopic situation, dark situation, and it's got a blue light. Blue light does not stimulate the pupillary reflexes as much, and that assesses the mesopic pupillary reaction. You'll be surprised to see that some myopes will have mesopic pupil of 6, 7, and if you do a 6 millimeter or 5.5 millimeter optic zone, they'll have a pathologic situation in the night vision. So angle kappa, as Dr. Deepi mentioned, is very important in hyperopia. Hyperopia treatment is in the periphery, not in the center, like in a myope. When you have the periphery, it acts like a convex lens, and then centration to the visual axis. Am I clear? Am I audible?
There's some disturbance just now. I'll just mute it.
So roughly when you do an ARK machine and when you ask the patient to look at the balloon or some target there, you watch the screen, you will notice that the central dot is not in the center of the pupil, it's elsewhere. It's either on the right side or left side, depending upon the direction of angle kappa. So you can suspect presence of angle kappa when you're doing ARK itself. Of course, Pentacam HR does not give accurate angle kappa. It's not angle kappa, but it shows the distance between the vertex of the cornea and the center of the pupil, And that's a rough guide as to how much you can decenter the ablation in a hyperopic patient. Of course, we routinely do a biometry in all the patients who go for LASIK, so that we have a documentation of how much is this biometry. And in case of regression, we know that it's not because of changes in the biometry. Of course, the eye cannot become smaller in hyperopia, but in at least myopia, when there is regression, you know that it's not because of decay in the corneal curvature. It's the change in the axial length. So that's some document you have. We do a topography, we do OPD3 scan, we do an OCT of the macula to see if there's any pathology, complete dilated examination of the fundus, Shermer's IOP, and the general health parameters are also looked at when you're doing LASIK. This is many of them are common with myopic LASIK. What is the limit of the Allegretto? Allegretto had the highest uh, plus number that we had. That was very surprisingly true. 6 diopter of plus. And these are in the built into the nomograms of the machine, and 6 cylindrical power, and that's approximately about 9 diopter of spherical equivalent of hyperopic and correct using the flying spot laser. This is an amazing power. In most of the presentations can be corrected within this without interfering with the standards of the machine. So you can treat with the flap or on surface. LASIK, femto, we have used all of them. We've used advanced surface ablation also. That's the, we have used transepithelial, we have used mechanical removal of the epithelium. We used epitome that we have in the hospital where it takes away the epithelium using a microkeratome like machine and with alcohol. Of all the things we have discussed enough last time, my priority is the alcohol preparation because it gives the clear starting point for the LASIK to be done. Even today, though we have epitome, though we can remove it mechanically with brushes and all, though we have transepithelial facility, my favorite technique, whether it's hyperopia or myopia, is alcohol removal. The pain is by and large, if you're doing a surface, is eliminated. I've done a lot of work on pain. You have a contact, you place a contact lens in the cornea, you remove the epithelium with alcohol. Sometimes tomorrow, next day, you see there are fine tags of epithelium sticking there. These are moving. Whenever an epithelial tag moves on the under the moving contact lens, that's the one which causes hell of a pain. So at the end of the alcohol, you remove all these tags and you push it to the periphery till all these loose tags are removed. You can remove with the Marocel sponge itself. If you ensure that all the tags are removed and put a contact lens, these patients really do not have pain. They're very, very comfortable. So this is what, when you do a transepithelial, there are no tags left. But when you use an epitome or alcohol or mechanical, sometimes tiny tags can be left. They fold in and out under the contact lens. When the contact lens moves, like when you have a small wound on your hand, small touch of your hand, leave it itself, it doesn't pain. But when a cloth runs on it, and then it starts paining because the flap moves, edge of the wound moves. So that kind of thing can be tried to avoid the pain in ASA. ASA is compatible with low hyperopes. How do we do it? Hyperopic eye LASIK. We paint the eye with powder and iodine. We put proparacaine. Do not put proparacaine on both eyes. We always generally start on the right eye. Put proparacaine or anesthetize only the right eye and do not anesthetize the left eye. Why? So when you ask the patient to keep both eyes open to avoid the cyclotorsion, this eye, because it's anesthetized, will dry up. And when you go to the left eye, you will have surprises because the epithelium is dried, and you may have you may not have correct treatment protocols applied on the eye. So always apply paracaine only to the eye that you're treating, and apply it just before treatment. You don't have to put half an hour before, just before treatment. Paracaine peak action is within minutes and it fades away very quickly. So there is no point in putting paracaine outside. And even while doing the betadine cleaning, I ensure that betadine doesn't percolate into the eye. It only cleans the outside, and no betadine percolates, and I don't have to put paracaine at all in the eye. I put it just before I start the treatment. So you put an eye shield on the other eye. This is one of the most important thing in hyperopes, because when you put an eye shield and when you drape the patient, in case the drape is touching the cornea or even the lids of the eye, the patient tries to move the eye or tries to close the other eye to protect it from hurting. So there will be a cyclotorsion in this eye. If you want to avoid the cyclotorsion, put a shield, encourage the patient to keep both the eyes open. This is very, very critical in all treatments. The face should be parallel. You always see from top. You also go to the side of the patient, see the profile, and you can put the chin down or chin up depending upon whether the face is parallel to the floor of the floor of the table or floor of the OT. This is again very important. Face has to be parallel to avoid anomalous treatment, and fix the microscope position. Put a drape, you move it and fix the microscope position so that the laser light or the red light is on the cornea. This is again very important. After you drape, like you have draped it, the patient might have turned the head to that side, this side, and again you're adjusting it again, and all these adjustments go waste. So chin level has to be adjusted. Focus the microscope on the patient's eye, and whatever you want to do it with the joystick right now, and then put the drape. After you put the drape, there's no head tilt, no rotation, no chin elevation depression. You put a suction drip and irrigate the whole eye. And now I've done it. Now you see that the laser light is here, not in the center. Normally what we do is we put our hand there and push the joystick and push the whole head on this side. Don't do it. Move the patient's head and bring the patient's pupil back to the light. So that way you're sure that under the drape, the patient's head positioning is perfect. This is very important in hyperopes, and it's important in myopes too. So do not operate the joystick after you've draped the patient. Adjust the patient's head to ensure the centration. We use Amadeus microkeratome, thin flap technique. It's again very important in hyperopes because you're taking a large flap. You're taking a 9 millimeter, 9.5 millimeter flap. The single most factor that affects, we did a study, I think Dr. Jyoti presented it last time. All the parameters that can affect the corneal thickness was analyzed. I'm happy to know that logically I thought we are going to apply vacuum on the eye. If you put downward, normally what is the classical teaching? You apply a lot of downward pressure on the eye. You apply pressure on the eye, so you push it down and then activate the foot switch so that vacuum builds up. What have you done by pressurizing the eye downwards? You're prolapsing the cornea into the foot plate. Your cornea is prolapsed into the foot plate, so the suction that you take is going to be thick suction. That's logically correct. So then why are the people trying to tell us to push the eye so much inside? That is because to avoid the damaged corneal flaps being raised. So today's microkeratomes are so good, and you'll have to ensure that the entire limbus is touched by the foot plate. Entire thing is touched by, you can actually touch it and lift it, touch it and lift it, just touch it, no downward pressure, and activate the foot switch. And then the prolapsing of the cornea, the anterior segment into this ring is going to be minimal, and you're going to have a very thin flap. We did a study on this, and if you just touch it, activate the foot plate, and then set the vacuum right, then the corneal thickness was proved to be extremely thin. Some of the flaps we raised is around 90 microns, 100 microns consistently, even if the blade says it's 120 micron blade, 120 micron foot plate. So how much downward pressure you applied on the eye before activating vacuum? If you apply less pressure after activating vacuum, you release it, then again the flap is going to be thick. So uniplanar large flap obtaining in hyperope is important because the flap is going to be large in these patients. Now we come to the most important aspect, myopes versus hyperopes. Hyperopes have larger angle kappa. There are so many anatomical parts in the eye: the pupil, limbus, the vertex. Vertex is where the Purkinje image is seen, and the pupil center, and the visual axis. Visual axis is impossible to see. No machine can see or identify visual axis anywhere. It does not correspond with the pupil centers. It does not correspond with the geometric center of the cornea. When you take a limbus as a circle and put a dot in the center, does not correspond to the anteriormost part of the cornea, does not correspond to the vertex. Vertex is the light, bright light. You ask the patient to look at the blinking green light. That's to make the eye coaxial to the laser beam. Imagine that's a blinking green light. The patient will align his fovea to the blinking green light, and you're going to see from the top, and you will never be able to identify a visual axis. It's impossible. Now, why is it important? What is the anatomical point on the corneal surface which is closest to visual axis is the Purkinje 1 image. It is not on Purkinje image, but it is closest. Otherwise, it's called vertex. Whenever you take a picture on topography or OPD3 scan or a pentacam, it gives a value. It gives a value where vertex distance is located in relation to the pupil or in relation to the corneal diameter. So let us look at what we can do with this knowledge that we have. This is the classical picture of face of a hyperope. What do you see here? There is an exophoria or exotropia. This is pseudoexotropia. See, hyperopes have to just remember this sentence. All hyperopes or most of the hyperopes will have pseudoexotropia. That means they are looking at the light not through center of the pupil, but in the medial portion of pupil. Can you see that? That's a pupil there. The Purkinje 1 image or the corneal vertex is medial to the center of the cornea. So there is an apparent exotropia in these patients. So what is the distance between the pupil and the light reflex? It can be measured in microns. 1 millimeter is equal to 1000 microns. So that is the value that comes up in your printouts or in your pentacam printout or OPD3 scan printout. That is the called angle kappa. So look at these four eyes. It's logical to imagine that the patient should be looking at the central dot of the central camera of the topography, or central target on OPD3 scan, or central we especially in pentacam, we spend a lot of time in telling the patients where to look at. We'll actually show a diagram. There is the blue rectangular mark. Inside that there is a red dot. Inside the red dot there is a blue dot. So you sit and see what do you see there. What is the target there? You'll have to explain to the target, because very soon patient will be looking somewhere else. Especially that when there is a moving object like a pentacam, the camera moves, shim camera moves all around. Patient has a feeling that he should rotate the eyes, and all the drawings that you get is wrong. So you'll have to sit and see what do you see in your machine in the center. You'll have to tell couple of times to the patient, look at that point. Like in a pentacam, I see a blue rectangle, a red dot in the center, and a black dot. Patient will say, tell him that when something moves around, don't move it. First drawing is always discarded, always repeat it second, third time to get good scans. So you can see here, the Purkinje image or vertex is away from the center of the pupil. And again, you can see here, this is the dilated, mid-dilated pupil. When you put a hood there, that is contracted when the light is bright. The pupil actually shifts nasally whenever it constricts. You can see here, it also gives a value. The pupil in the distance is 0.0403. Here it is 72. The center of the pupil can be different from the actually Purkinje image depending upon the status of the pupil. So if you have recorded your pentacam or topography in bright light, and now you have come to the laser room which is dim with the dilated pupil, the values of your angle kappa are different. Angle kappa varies depending upon the pupillary diameter. So as you can see here, this is the photopic pupil, that's the scotopic pupil. In this patient, they are identical, and sometimes it can be hugely different between the dilated and constricted pupil. Now you can see here, under the microscope, the patient is asked to look at the blinking green light. He's looking at it. That's a corneal vertex. But when you ask the patient to start treating without decentering the image, it is going to see the pupil, and all the ablations are around the pupil. Like that's the center of the pupil, and all your ablations will be centered to that. So what you're supposed to do, you ask the machine to decenter. That is, instead of treating the center of the pupil, you treat to the right side by so many microns. You can put it to the controls, and now the machine understands and start treating around this point. So we decenter all the eyes, whether it's a myopic or hyperopic eyes. I identify this, and on the laser machine you can calculate the distance, and then you can decenter the ablation. So as you can see here, this again the topographic picture. You can see that that is the pupillary axis, and that is the visual axis, are closest to the corneal vertex. And now when you want to treat it, cylindrical power, you'll have to treat around the vertex. But if you ask the machine to treat, it treats around that. So now you have to decenter the ablation like that, so that now it treats it. Now you're decentered not only towards your left side, but also downwards. So these can be entered into the machine. This is the corneal vertex power as given by the pentacam, plus 0.29 on x-axis, plus 0.23 on y-axis. How do we transfer it onto the patient's eye? So that this comes here, somewhere here. So that's the Paki. That is the x-axis distance between the pupil center and the vertex, and that's on y-axis. Now, when you look at the eye, you're looking from the head end. Now, when you're taking it, you're looking from the front. Now it is upside down. You can imagine that. So now, how do we do it? Minus 0.35. You'll have to move it. That is the chart that we have written. This is a left eye. You'll have to go to the left eye chart, or a right eye chart is equivalent. When you say on x-axis minus 0.35 means, from that point, you will have to go 350 microns to the left side. This is in millimeters. So 350 microns on the left side. So anything to your left side, as you are seeing from that angle, is on the minus side. Anything to that side, whether it is a right eye or left eye, whether it's temporal or nasal, anything that's on your right side is plus, anything to your left side is minus. Always remember on x-axis, that's the x-axis. This, if you want to do it, you have to decenter towards the temporal side in the left eye, and if it were to be the right eye, towards the nasal side. Always remember this, patient's face. And on y-axis, you'll have to decenter 0.19. That means you'll have to come down, come towards you. Actually, in relation to the patient, you're going up towards the head. So here on the, as you see here, come down here by 190 microns. So you'll have to decenter 350 microns to the left side, 190 microns towards your side to get the best optimal results. But these are done in bright light, in an ambience which is in the clinic. But now we are treating in a different kind of light, much less than this. So these readings will be wrong. So you'll have to actually measure and evaluate whether these readings are right or wrong as you're doing the LASIK. So that is also possible in our Allegretto machine. You can actually measure it by something called center test, and you can enter the data. You can enter the data there and do a center test. What does the machine does is, machine initially brings this spot right in the center, then it goes to the new center and comes there. So you have to see whether the green light is aligned to the new center on doing center test. If it is aligned, go ahead with the treatment. If it's not aligned, you can actually meddle with these values and get the correct values. So this is possible to show on the machine itself. So you can enter the data. Here I've added 150 plus micron decentration on the x-axis, y-axis it's 0. And it can be changed by modifying the joystick. You can increase or decrease by modifying. The technician will help you out in that. The next thing is, now in this patient, if you decide to, this is a practical problem. Now, sometimes the decentration can be very large. It can be 500 microns, it can be 600 microns. You can choose to decenter 100% or you can choose to decenter one half of it, one third of it, or two third of it. It's ideal to choose. In a very large decentration, I choose about two thirds amount of decentration. In a smaller, medium to small, I choose 100% of decentration. The when you decenter from the pupillary center towards the nasal side, always in hyperopics on the nasal side, when you start ablating on it, imagine that the flap sitting there. Some of the ablations will fall on the flap. This you'll have to avoid. The flap, under the flap, ablation should be avoided. Otherwise, see, in this area, this portion is normally ablated, and this flap is going to sit on that. This is also ablated. So in that particular area, there will be double ablation. In this area, there's going to be double ablation. So there's going to be a dimple there, and that can give rise to very bad results post-operatively. And also there can be sometimes a scar in that area, whitish scar or epithelial. Some debris will start accumulating because there is double ablation. So how do I avoid it? One way is to cover this up with a morosal sponge. You bring the sponge from nasal side, see that it does not obstruct the tracker. Otherwise, tracker will not run properly. Tracker runs throughout the ablation. You cover it up with a morosal sponge so that the ablation under the flap do not occur. Otherwise, what you can do is, what I normally do is, I decenter the flap itself. Normally, we center the flap to the cornea. Okay, you put the microkeratome ring on the cornea, center it perfectly. Now, what I do is, if I have to do a large decentration, the suction apparatus itself, I decenter towards the nasal side. So when you put the microkeratome, don't put it microtome center to the cornea, put it half millimeter towards the nasal side. So this line will be much more nasal side, and we can avoid certain amount of ablation on the undersurface of the flap. So this decentered flap, I was wondering whether it will give rise to any optical abnormalities when I finish the laser, but in spite of the flap being decentered nasally, I've had no surprise cylindrical power, I had no surprise higher order aberrations, I had no surprise spherical corrections by doing this. So what I'm trying to tell you is, decenter the flap initially, depending upon how much of decentration you're going to do it, and in spite of it, cover it up with the morosal sponge, holding it from the nasal side so that you don't block the uh, tracker. So most of the time, we take larger optical zones of 7 millimeters and larger ablation zones, and do not ablate under the flap, as I said. And the eccentric flap is something which is very useful and a very novel technique of preventing the double ablation in the nasal side of the cornea. So the flap itself goes to the side, as you can see. Now, visual axis is a fixed line. I have covered this. Pupil center changes with pupil size uh, and shifts towards the inferior nasal side on dilatation. And angle kappa is reduces on dilation. Angle kappa is larger in small pupils. So pentagram HR is always done with undilated pupil, because if we do with the dilated pupil, then it will give anomalous vortex distance. And reassess the angle kappa just before ablation in every case of hyperopia to get excellent results. And so we have done a lot of decentrations. In the right eye, we have done decentration. For example, here the on X is the minus 0.46, that 460 microns. On Y, it is 4 microns. Here we have decentered 350 microns. And in the left eye, we have these are left eye statistics, but what is up there is here 510 microns is there. We have decentered 300 microns. Here on Y side 50 microns. So a lot of decentrations need to be done to get good perfect values results in this treatment. Hyperopic treatment is always longer. So it takes a lot of time because tissue that's ablated is longer. It takes 4, 5, 6 seconds. You'll have to keep talking to the patient, ask him to look at the green blinking light throughout he will be able to see green blinking light throughout the ablation. So you should be able to ask him to not to move the eye and not to blink, keep both the eyes open, and keep looking at the green light all along. And all these are very important. And in spite of the tracker doesn't do 100% of the job. We'll have to keep telling the patient, I tell him 50% of the treatment is over, 80% is over. Now treatment is completed. Just encourage him to keep both the eyes open. That's very, very essential. We did analyze 200 previous consecutive eyes. 188 eyes underwent decentration. That's the importance in hyperopia. 12 eyes were there were no need to decenter in 12 eyes, and uh, we also have done double hyperopic corrections because machine allows only 6 diopters of spherical correction and 6 diopters of cylindrical correction. In some cases, like for this person has got 7.75 diopters, and we wanted to give the best of it. He conformed to all the criteria to satisfy. At the end of ablation, the K reading should not be very steep. You should not go beyond 48 or 49. So you should start with low K readings, if little flat cornea. See if we satisfy all of them, we can take the patient for double in the same sitting, double ablation in the same sitting. So how do we do it? So take this example, this patient has come, he is satisfied with all of them. Central K reading, central Pachy is not very critical because Pachy central cornea is not thinned out. Its thinning always happens in the peripheral, mid-peripheral cornea. So in the first treatment, both the treatments are loaded entered in the first itself, so that consecutively we can make it. Full cylindrical correction at correct axis. Always correct full cylinder. You see in spectacles, sometimes we undercorrect the cylinders, but in LASIK, we always correct the cylinders first because then only you will get the 6.6 or 6.5 vision. And at the correct axis, and 7.75 is the correction. I correct 6, that's allowed by the machine. And then there is a residual hyperopia of 1.75. So now, but we have changed the K readings, we have changed the corneal thickness. Both are changed now. And in second one, the hypothetical K readings and is to be entered and refocus on the new cornea, the ablated cornea. So in the second treatment, we take the K readings and Pachy. Pachy is also thinned out in the center, not much in hyperopia, but in myopia, thinned out too much. So that has to be considered enter. And but keep the optical zone and keep the ablation zone absolutely same and same amount of decentration. Don't change them. And these are the entries. You can see second is 1.75 and 6.5 optical zone. Ablation zone is 9 millimeter. Everything is fixed. And you finish first ablation and then go on to the second ablation immediately. How do you take the keratometry? Keratometry also changes, and you can see we looked at the what was a pre treatment keratometry and post treatment keratometry in a hyperopic patient, and we calculated how much is a post LASIK keratometry. It comes to about 0.5, depending upon the initial K rating, it comes to about half diopter to 0.6 diopter for every 1 diopter correction in the hyperopia. So if you have corrected 6 diopters, so 6 into 6, about 3.6 dioptric change will be there in the keratometer, and that has to be entered in the second, second treatment planning. So see, this is how the OPD3 scan looks like post-operatively. You have got beautiful. This is after double ablation. Beautiful, very well centered. This is a steep cornea and ablation, absolutely centered to the center. This is pre and post. And pre-operatively, there is a lot of disturbance in the point spread function. Post-op, it's tolerable. And that's the quality of vision after double ablation. So patients have been extremely happy, even in correcting more than 6 diopters, which is recommended by the manufacturers. So FCAT, I think we are going to take it next time. PresbyLASIK, I'm not going to cover it, but this machine is extremely good in correcting presbyopia by using ASIS nomogram. We got very good results by using ASIS nomogram. We calculate the amount of, that's the calculation as you can see here, and the patient will have an aspherical Q value, aspherical cornea to improve in a much better way. And this is the patient who had extremely good vision. First post-op day, 6 part and N6 vision after the Presby corrections. We modify the Q value, as you can see here in the left eye. We have not modified the Q value. Q value remains same. In the right eye where we did a Presby LASIK, post LASIK, Q value has changed from minus 0.15 to
నానా
minus
నువ్వు
1.06.
ఒక్కదానివే ఉన్నప్పుడు
There's one
ఇది
diopter change
లేకుండా
in the
విను.
Q value that adds to the reading vision. This is a Presby FCAT. That's an optimized treatment where Q value, there's not much change in the corneal sphericity. So we did this analysis of 76 consecutive cases of hyperopia. There are no intraoperative, no short or long-term complications. We have had excellent results. In no case we had any regression. So 37 eyes right eye, 39 in the left eye, 47 eyes of 28 men in the men were much more than women for certain reasons. Average age is much higher. Age is around nearly 40 years. Youngest is 18 years, oldest 66 years, because most of the eyes, +1, +2, +3 is camouflaged by the patient's accommodative efforts. 41 had hyperopia with presbyopia because they're above 40 years age. Average Q value was 0.24. That's an average. Average thinnest cornea was that. Axial length was shorter when compared to myopic eyes. The lowest correction we did was ferrocylindrical correction, and highest was 9.5 with 1.75. 58 were microkeratoum, 13 were femto, 4 were ASA, was much smaller because peripheral zone ASA is difficult to do. Transepithelial we did in only one eye. And almost in all of them, we did decentration. 64 had x-axis decentration, 32 had x and y-axis decentration. So this is interesting. And most of them had positive decentration. Only one had a negative decentration, being a hyperope. Optic zone was generally we take 6.5 or 7 millimeters in only one eye, where the cornea was the cornea was very small, and we adopted to a 5 millimeter optical zone. Generally 6.57, while in myopia we take 6 millimeters optical zone. The ablation in the center is 70 microns. Periphery can be as much as 288 microns in the periphery. No, all are peripheral. Central is almost zero. 70 microns is average. Range is from 30 to 288 microns. So 3 patients we did double treatment. The highest power that we treated is 8.75. So 4 years follow-up, there is no regression. Vision even after 4 years. As you can see, there is no scarring. You can't see the flap. You can't see even the flap side, nasal side. You don't see any scarring there because of the shifting of the flap making to nasal side, and even the cornea doesn't show any. On densitometry, there is no haze on the cornea. So I wanted to present this because many times patients are refused hyperopic treatment. We don't even talk about laser treatment for hyperopes. The success is because we did a very good cycloplegic refraction, not once but two. Cycloplegic refraction is once, but at least dry refraction we do 2 or 3 times. Large and decentered flaps, thin flap technique, the way I explained to you. Optical zones are larger, treatment zones are also larger. Angle kappa has to be meticulously looked at and actively managed, and customization like double ablations is to be done whenever it's necessary. So that is the hyperopic LASIK from my side.
Thank you so much, Dr. Ravindra. Very elaborative and very thoughtful points, very practical points. So we have a few questions here. Does LASIK correction correct the ESO deviation in patients with accommodative esotropia?
See, this needs to be corrected because it does not correct. It does not correct any of the phorias. It's not possible to correct it. But then you're not accommodating. The main thing that bothers us is when you are a hyperope, you are accommodating, and accommodation itself will correct some amount of the muscular imbalances that you have between the two eyes. But once you fully correct it, that accommodative facility on the eyes is lost. Whether that gives rise to any binocular disturbances to these patients. We are doing a study on it. Actually, I don't have the statistics on it, but most of the patients, all the patients that we have seen here, and they have had no issues with binocular vision. But it cannot correct the esophoria or esotropia or exotropia. That muscular balance is independent of your uh, your refractive correction. Basically, whatever you did with the glasses or contact lens, you did with the laser.
But do you feel the correction post LASIK in the tropia is a little more when compared to glasses or contact lenses, or is usually the same?
No, most of the patients, as you know, in hyperopia, they're not fully corrected. They're
Correct.
undercorrected. There is a residual amount of hyperopia in majority of them, which they are correcting with the accommodation. So when you accommodate more to correct the uncorrected spectacle refractive error, that corrects some amount of it. This is a crucial thing that you'll have to look at, because if you in laser we correct it. Sometimes we correct it to such an extent that we encourage the patient to wear a -1 diopter power for distance. The patient complains of this. You can't take, like spectacles, you can keep prescribing higher and higher power. When you do a laser, you always do it fully, maximally, and then maybe the patient may have 1 or 2 or 3 weeks of distant vision problems post-operatively, which they should learn to relax their accommodation to correct it. So this, you have to talk to the patient, especially when the patients are grossly undercorrecting their glasses. And about the mention you said, whether when they fully correct with the laser machine, it's equivalent to what happens to their muscle balance when they fully corrected with the glasses. Nothing more and nothing less.
Okay. Would you remember the highest difference in a cyclo and a dry refraction you have seen in your hyperopic patients?
I don't remember often, but younger the patient, more it is. It
Okay.
can be as high as 3 and 4 very easily. But I don't remember the highest that
So this is a very
5, 5, 6 we have seen.
yeah.
+5, +6 we have seen in
So
hyperopics.
imagine the dry is 3 and you're getting a wet of 7. So can you just tell us step by step, how do you treat? How much do you want to plan? Any tips so that the patient is better prepared for this? So would you go full or would you go somewhere midway?
No, I think we'll have to spend a lot of time with the patients, our optometrist and the doctor himself. We and as a team we work together. I sit next to the patient, and when a dry refraction is being done, we keep pushing and pushing. The secret is do this, and you do an MEM. You do this and do a streak retinoscopy is very important in these patients. Dynamic streak retinoscopy is important. Put the maximum there, and the patient reads 6.5, then it drops to 6.6, do a streak again, and again give patient 2, 3, 4 minutes to relax. Do it on both eyes. Never close one eye, and never take out the lenses. Doing a refraction phoroptry is very important. Never remove the lens. The moment you remove it, he's going to accommodate. So it has to be even if I have to put the on trial frame, if there is a plus 0.5, I have to increase to 6. I don't remove the plus 0.5. Put +1 on the top of it and make it 6 rather than removing it and putting in the next one. There are a lot of tricks that needs to be adopted to not to allow the patient to accommodate and go back to his spasm. So step by step is you do the maximum dry refraction, and then when you do the wet refraction, you deduct 1.5 diopters for your distance. You know exactly how much is the total hyperopia that he has. My plan is to do the full hyperopic ablation and leave him, as I said, with -0.5 or -1 to begin with, and which he'll get over within 2, 3 weeks time. uh, it's a question of spending a lot of time with the patient, explaining to him to relax, and sometimes at the end of it, you do with both eyes open. Do a retinoscopy with both eyes open. Normally, we do with one eye and do the other eye. Remove the occluders, ask him to encourage. Then he'll be able to relax another half diopters. Try to reach the maximum that you've seen the eye has when you've done a hyperopic, when you've done a cycloplegic refraction.
And I think many of them we also do prescribe when there's a huge difference and the patient is explained, we do give them temporary glasses and lenses also, so that they're much more happy after LASIK and all these accommodative changes happen pre-LASIK. So I think if you have a type A personality who's you may feel may cause you trouble, we have done that quite often. giving full power, wait for a few weeks, and then plan the LASIK. So that
Yeah,
is
that's an excellent plan. Ask him to wear glasses or full correction, what you are planning to do it, and see how he experiences with it.
And what is the cycloplegic of your choice?
Homatropin.
Any,
Homatropin, yeah. It
any.
has to be homatropin.
So we had few questions on when is the second treatment planned? I think that's answered. Immediately after the first, your technician plans both the treatments. Second treatment, you're putting a different K and tentative different thickness, and immediately we shift over to the second treatment. The only
Refocus the machine onto the new cornea.
And only thing you need to change there is again re-enter the decentration. As the change in corneal curvature is more towards the periphery, chance of flap disbursement is a possibility. Is there a role for the use of contact lens in cases of hyperopia?
I have used contact lens only in one patient, and the contact lens actually is not a good idea. Just leave it, just like a myopic. This thing, it never goes unless the patient has rubbed the eye. So if you have used a contact lens, my trick now is the in only one patient in my initial 20 years ago, the patient had both the eyes, the flap striae was there. I asked the patient what happened. The patient said, when I opened my eyes in the morning, I was unable to open it. I had to force my eye open and opened it. That's the reason. So whenever you put a contact lens, advise the patient to put few drops of tear drops the moment he gets up, because contact lens would have got stuck on it in case there is a relative dry eye, and then movement of contact lens will also take the flap along with it. So in case you used a contact lens, you always put some lubricating drops the moment you open the eye in the morning. So that way any stickiness will get released.
Any difference in results between ASA and LASIK in your series of patients?
As far as results, so ASA we've not done many in hyperopes. As this show this thing, I was only worried about large amount of ablation occurring in the mid periphery, giving rise to the scarring there. So we have not done many ASAs. In lower hyperopes, yes, we have done it. In higher hyperopes, it's always under either macrokeratome flap or femtosecond flap. The difference should not be there. Both of them should behave differently because the ablation is same on the surface. It's reflected onto the surface when you put a flap there. It's same as what ASA has done. ASA will certainly cause little more haze in the periphery, and you'll have to use mitomycin in the periphery, which is close to limbal stem cells, which is always a worrying issue.
Hyperopic LASIK for candidates in defense sector.
What does it mean?
Dr. Narasimhan sir, do you want to elaborate? What specifically?
Actually, can you hear me?
Yes, yes.
Yes.
No, I just want to know your experience, like candidates who have come with the hyperopia and you have done the LASIK for them. Are they eligible for the defense sector, like, candidates going for interview and all that?
Okay. I'm not sure. See, I don't get many defense patients or candidates from railways, or I'm not sure what it says, but whatever that should apply for the myopia should apply for hyperopia.
Okay.
I don't think they're going to differentiate between the two.
Only concern there, sir, we'll have to see if he's improving to 6/6 because many of them may be amblyopic. So
Correct.
do a vision therapy and then start over. If he's really keen, it's only for defense would be. We have had a lot of patients, but I've never had a my hyperopic for defense. So
I know. That's the reason why I'm asking. Yeah. Even I have not
criteria should be
seen anybody. Yeah.
criteria should be same, only that amblyopia part probably.
See, if the
Okay.
quality of vision wise, pre-treatment with the glasses or contact lenses and post-treatment, there were some comments that, like in the literature, they say they don't improve up to as much as they used to do it before, especially because with the glasses, the image gets magnified And when you do the laser, the image is not as magnified as it was before. So, but we in the best corrected visual acuity before treatment and after treatment, we have not seen any reduction in central vision after hyperopic treatment, even in higher hyperopes. So that's not an issue.
How were the results in amblyopic patients? That's
I
another.
would say excellent. Amblyopia with central fixation, superb. I mean, actually, the vision improves a lot after that, especially when you put the patient on vision therapy. Vision therapy can be now not restricted to age of 9 years. We do vision therapy in 30 years, 40 years, 35 years, and the vision improves in all patients of amblyopia without treatment or with treatment with LASIK. But there are very powerful tools available today to improve the vision in an amblyopic eye. In eccentric fixation, it's always a challenge, and it's impossible to change the eccentric fixation to central fixation after the grinding of the development of the visual axis. Then there the undercorrection remains.
What, according to you, is the best instrument to measure angle kappa?
There is no best instrument. Angle kappa is, I would say, in a hyperopic patient, because I always observed the pentacam values of distance between vertex and pupil center, what is printed and what I actually do it, there is a huge difference. Sometimes plus has become minus under the machine. So the most accurate measurement for laser treatment is the decentration done under the machine. So now I know exactly, if I see the people, I encourage the patient to look at the green light. By looking at this spot, the green spot, that's the Buck-Giovanni image of the vertex, I can roughly tell it's how much is on plus side, how much is minus side on the y-axis and x-axis. I'll tell my assistant to do it, and 10, 20, 30 microns readjustment is necessary, but by and large, that I think is the most accurate way, rather than depending upon the values given by OPD3 scan report or the pentacam report, which generates the values when the patient is sitting down looking at the chart, and the evaluator, the technician might have asked him to look at the target or not. When I'm there, I ask him to look at the target. I know exactly how much it is. He might be asking that interaction with the patient by the technician is extremely important in finding out and measuring the angle kappa.
And another one saying epithelial remodeling to recurve the cornea can be the cause of regression. Yeah.
Yeah, this is one of the reasons why there was a regression, both in myopia and hyperopia in older machines. Nomograms were not good. So now the 6 diopter or 10 diopter, 9 diopter, whatever nomograms that machines give today is well calculated to have a smooth ablation pattern. If there is a sudden change in the corneal topography created by the LASIK machine, you have epithelial remodeling. Epithelium tries to fill up irregularities basically. But if you plan it in a nice way, you have a large optical zone. That's why you should have an optical zone of 7 millimeters in hyperope. It's large. When you have a large optical zone, the sudden changes in the contour of the cornea will not be there, and the epithelial remodeling also will not occur. So I have not had any surprises over a period of time when you follow them up due to epithelial remodeling.
And there's another comment that both pentacam and variotopalizer can give good and comparable angle kappa readings. It doesn't give angle but distance between the pupil center and vertex. Any difference in your steroid regime as compared
When you use the vario or topolizer, there is no need to correct it. You don't have to do anything. Machine itself identifies it, but you'll have to confirm it by doing a center test. It may be wrong. As I said, it may be a wrong reading. So you'll have to confirm whether it's right or wrong by doing the center test. In the center test, when you press, actually the light hits, the yellow light hits the pupil center, then it shifts to the new center, a new ablation center. So that you'll have to watch it.
Correct. And that actually is a limitation. Now, say your x-axis is matching, your y is not. So with a vario, we cannot change only one and continue with the other. It should be either 25, 50, 100. So many times we switch over to a manual decentration for this advantage because we can override that and manually we can set it on the visual axis. And any difference in your steroid regime as compared to myopic LASIK? I know we have.
I use only the fluoromethalone drops, only fluoromethalone and flurbiprofen. This is my favorite for last 20 years. Never burned my fingers with that and use it for about a month's time.
Early age for LVC in hyperopia. What is the earliest
See,
age?
hyperopia, you can do it at any age. I'm not done on children because there is no, in myopia, the eye keeps growing and the power keeps growing. So in hyperop, it's short eye. So eye cannot become shorter and shorter for the hyperopia to increase. It's already built in. So eye can only grow and reduce the hyperopia. So 18 years is cutoff time, and but number of hyperopes we treat is much lesser than myopes because many times they are hidden. We don't even know that they are hyperop. So the age wise, I'll just keep it as myopic ages as the limits in that. But I always look at the possibility of treating like anisometropic amblyopia. There are people who treat amblyopia with laser machine at much younger age, but we have not tried doing that.
So another question would be, would you prefer ablation on surface or under the flap in residual hyperopia in pseudophakic eyes?
In a pseudophakic eye, always on the surface because the treatment is not going to be much. It's going to be a small treatment, and it can be done on.
I think we can discuss a little bit with Presby LASIK today also. So there's a question on what is the maximum Q value you would want to achieve and in which eye while using the ACES nomogram for Presby LASIK.
See, Q value, the presbyLASIK is done on the non-dominant eye. Dominant eye, leave it for routine work, for distance driving, because the patient is going to use that most of the time. Your reading time is much limited, and you'll have to choose the patient. All patients are not fit for unilateral presbyLASIK. PresbyLASIK can also be done bilaterally, but we've always prefer to do it on the recessive eye. The maximum we can push is about one. Uh, you know, uh, what do you call the Q value is changed to about 1. If the Q value is also high, there is a limit to which you can push it. If the Q value is lower, then you can push it higher and higher.
Can we perform hyperopia with PRK? I think that we have covered.
Lower powers, yes, not in higher powers.
I think we have covered most of the questions. Okay.
Yeah, that's
Now,
another comment. In the X500, there is an option of changing the decentration by a fixed amount of. Yeah, that's right.
yeah.
So, see, basically, the vertex is a very funny figure. It's not visual axis. Imagine there is a line which connects your fovea through the optical system to the object of regard or target, and that's the visual axis. Where it touches the cornea, nobody knows. It can be anywhere in the pupil. Usually, they say it is in between the vertex. Vertex is where you see the Purkinje image in a coaxial viewing. Hopefully, in the laser machine, it's coaxial. Nobody knows again whether it's coaxial or slightly decentered. In an operating microscope, it can be coaxial, it can be 2 degree, 3 degree, 4 degree away from your visual axis. So there is a lot of play around to find out where exactly visual axis. Visual axis hopefully stays somewhere between the corneal vertex and the pupil center. Okay, where it stays, nobody knows, and it's good to correct it fully in lower hyperopes and in not in lower hyperopes, in lower Q values, but in higher Q values, limit to about 50 or 75% of the correction. In higher values, don't go. If it is, I have a patient with, with good foveal fixation. The patient has 1.2 millimeter of Q value, but they can't go to 1.2. limit to about 50% or 70% of that.
Another question on amblyopic vision therapy. Do you feel there is a difference when a patient has plus C number glasses and undergoes amblyopia therapy versus already corrected on the cornea and then undergoes an amblyotherapy? I would say office-based therapy where you're using gadgets.
Yeah. Both are good options. It's like there's you know uh, in a smaller way. If the patient is younger, you can always try out the vision therapy first, and then improve upon the vision, and then go for. It's not like a squint surgery where you get the vision therapy done and then do a squint surgery. Here, you do it, and then you take the patient for laser treatment. The
But
other way, imagine there is a lot of anisometropia. The anisometropia is huge, too huge, 6 and 1, like that. So it's good to, recovery will be much faster if you have presented similar images to the patients there rather than a larger and a smaller image during the vision therapy. And in such situations, large anisometropy, you can always choose to start with the laser treatment and then take him for the vision therapy.
and if you have a patient with squint and hyperopia, so how would you want to plan the squint surgery and the chronology of the treatment in such a patient?
Yeah, see, in such a patient, again, it depends upon the amount of squint, nature of squint, intermittency or constant squint, whether how much is the binocular vision. If binocular vision is intact, he's got a very strong reason to keep the squint correction squint intact post surgery. So, in all these patients, if they opt for both of them, I would like to do a laser treatment first and then take the patient for squint therapy, because laser itself will modulate some amount of balance between the two eyes. It's not that it'll correct the squint or angle of squint, but at least the if there is an existing binocular vision, if you have removed the refractive error, there's a possibility that the patient may fuse the images with the existing, reserves that he has, and he may, in a small squints, you may avoid a squint surgery. So I would like to do laser vision correction and then evaluate the patient again for squint therapy.
You would wait for how many weeks or months post LVC?
Post laser vision correction, at
2
least
years.
about a month or two, at least 2 months time.
Okay, fine. I think that covers most of the questions.
Yeah, any special case for a compound hyperopic astigmatism? They're nothing. Most of the case will have compound hyperopic astigmatism. You treat it exactly the way you're planning to treat. You should always remember whether you want to treat fully the astigmatism or not. You also know that all the withdrawal astigmatism will come down by a small amount, and against rule astigmatism will increase with the age. So you can keep that in mind, but it's not going to be more than half diopter. Like every 10 years there is some amount of conversion of withdrawal astigmatism to against rule astigmatism, and that you can keep in mind when you're laser ablation doing in a young person.
Great. Fine. I think that covers most of the things which were planned and most of the questions. Yeah. So I think we can end it for here. Dr. Prashant, anything else you would want to add?
Nothing really. I think everything has been so well covered, and it's a very comprehensive presentation. So it was. I don't think anything else is there.
Thank you so much, Dr.M.S. Ravindra, for a really very wonderful presentation on a very topic which has been a dilemma always. And I have seen the results. I've seen your results for decades, and I would say whatever he said really, really very important practical points. And we have never had issues with low or medium or high hyperopic treatments. And I think they are the happiest patients on day one compared to because they don't see distance, they don't see near, and the glasses are cosmetically much bad than myopic. So truly hyperopic patients are your happiest patients. And I thank each of you for being a part of this. And thanks again, Dr. Ravindra, for a wonderful presentation.
Thanks to all of you, and I wish you all the best year after year, week, month after month, and week after week. This episodes should continue forever, and that's a great service to people who would love science and would love to help their patients. Thank you. Good night.
Thank you. Thank you.
Good
So
night. Thank you, sir. Thank you.
Thank you.
good night.
Good night.